So dear participants, now we are going for the second topic for today's webinar, and it's medical management of colic in horses. So may I request Dr. Siju Simon to introduce the speaker.
Good morning, ma'am. Warm greetings, ma'am. It's my privilege to introduce Elizabeth Carr, ma'am, for this second day webinar seniors. Ma'am is an associate professor, associate chair in large animal clinical sciences, College of Veterinary Medicine, Michigan State University, USA. And ma'am, topic for the presentation is medical management of colic in horses. Ma'am completed BS in Cornell University 1982, DVM in Tufts University 1989, internship in Washington State University 1989, residency in Veterinary University of California, Davis 1991, diplomate in American College of Veterinary Internal Medicine, Large Animal Medicine 1994, Ph.D. in the University of California, Davis 1999, diplomate in American College of Veterinary Emergency and Critical Care 2006, CVA certified acupuncturist in 2013. Ma'am is also a clinical and research interested ma'am. His interest is clinical care, critical neonatal medicines, critical care medicine specialist in area of improving care, pathogenesis and treatment of equine sarcoid, equine herpes virus latency. With this introduction, I like to invite ma'am for this lecture.
So I want to say good morning, but I believe it's evening for you guys. It's 9 a.m. here and it's a beautiful sunny day. So a great day to hopefully give a lecture. So my goals today is to talk to you about equine colic and hopefully to discuss a little bit about how to determine what type of colic you might be dealing with and some ideas for treatments. So specifically, in this outline, we're going to talk about the evaluation of a horse that's presented for colic, as well as the diagnostic assessment, the standard sort of workup that we would do, and then discuss some medical treatments that you might institute to try to get resolution of the problem. So the goals are, when I see a horse that presents with colic, my goals are a couple. My first one is to try to determine the most likely cause of the colic. Obviously, I work at a referral facility, so we have the option of taking animals to surgery if needed. And so many times, that's one of the big questions I have is whether or not the animal is presenting with a disease that I can treat medically or a disease that I need to take to surgery. In line with that, because it is important that the animal be stable if it's going to go to surgery, it's very critical to determine the cardiovascular status. And by that, I mean, is the patient hypovolemic? Is it shocky? And does it look endotoxic, or does it have systemic inflammation? Because those are going to be important parameters to help me in terms of both preparing an animal, but also they are helpful in determining the type of colic, because many surgical colics will often have a history of presenting with a fairly recent or episode of colic, so a fairly short duration, but may present and look very shocky. And that can be an indication that they may have fluid volume sequestered, let's say, in their intestines. So, for example, a large colon volvulus, or where the colon twists around, as that colon is twisting, the arteries are still pumping blood into the colon. And so the colon can actually sequester quite a large volume of blood. And as it continues to twist and suddenly that artery gets cut off as the pressure builds, you have an animal that might be in fairly severe systemic shock. And so that can also be an indication of whether or not an animal might require surgery. So obviously, another question I have is it a surgical or medical? And then these all come together to help me determine a treatment approach. Obviously, in the field, the other question you would have is whether or not the horse requires referral to a facility that potentially can do surgery, or maybe can at least put them on IV fluids continuously, et cetera. And then probably the other important one we have to consider is prognosis, because even if you have the ability to refer a horse to a facility that may be able to treat the animal, it is important to consider the prognosis. If you have an individual horse that, let's say, is in very severely compromised, and you work it up and maybe find evidence that it appears to have some intestinal rupture, it's probably kinder and wiser to talk to the client about the decision to euthanize the horse, because the long-term prognosis for an animal that, let's say, has a bowel tear or a bowel leak is very poor, rather than putting that horse potentially on a trailer and referring it to a hospital where, one, it's going to suffer longer, and two, the costs are going to increase without necessarily a very good chance of a positive outcome. So to begin with, when we talk about colic, we automatically assume it means pain usually of the GI origin, but it is important to remember that you can have horses present for colic that may have nothing to do with the GI tract. And every year this happens, that I get a case referred in that is thought to have some GI pain, but in reality may have other types of pain. For example, they might have a stone in their bladder, or they might have stones in their liver that are causing stretch of those organs, which is quite painful. Kidney stones as well. Another two fairly common ones are laminitis. People will often think they're painful, and or if they have muscle injury, let's say they've tied up. And then pleural pain. So a horse that maybe has pleural pneumonia can be quite painful in the acute stages of that disease, because pleuritis is a very painful disorder. And then obviously when you're considering the abdominal organs as far as for colic, don't forget uterine or testicular torsions can certainly be presented for colic, or obviously bowel herniating into the testicles or other rings. So colic obviously can have many manifestations. Some of the mild signs we might see are just horses occasionally looking at their belly, pawing, stretching out, curling their lip. Some horses will just change their behavior. They may just play in their water or grind their teeth, and sometimes just standing in the back of the stall being unresponsive to their normal cues. You know, we walk up and instead of coming to the front of the stall, they have their head in the corner down as if they're just not happy. Can be milder signs of colic, as opposed to obviously the more severe signs of horses down and rolling, breathing hard, sweating, abdominal distension, like this picture of this foal in the bottom picture. And remember, this isn't 100% accurate, but sometimes the severity and the acuteness of the pain can be an indicator of the type of colic. Not always, but in general, more severe pain and with an acute onset can often be an indicator of a bowel twist. These are obviously just some other pictures. You may see a horse with shavings all over its body standing in the stall and recognize that horse probably has been down and rolling. Obviously, horses like to roll in new, freshly bedded shavings, so they may roll normally. So it is important to determine whether or not it's a normal behavior or pain. When working up a colic, I think there's a lot of things in the history that are important in terms of helping give yourself a smaller differential list. So the age or the breed or the sex of the animal. Of course, newborn foals, retained meconiums are fairly common. Ruptured bladder can cause colic, and even congenital malformations or congenital disorders like lethal white syndrome in paint horses. With older horses over about 15 years old, we tend to see more commonly strangulating lipomas, and they're actually more common in Arabian horses, for what it's worth. Miniature horses, I don't know how many miniature horses you guys see, but they're notorious for eating things they shouldn't. They eat the tail of their moms, they eat shavings, they eat string, and so they will frequently present with signs of large intestinal obstruction and have what's called a fecalith. And these are difficult to manage because they're not your typical feed impaction that you can break down with fluid. They're actually a mass of things that don't typically soften with fluid therapy. And so they may often need, lubricants and or surgery to resolve them. Again, reproductive horses, we think of inguinal hernias. Mares that are mid to late gestation, we think of uterine torsions. Post-foaling mare, you might think of broad ligament hematoma. And of course, a large colon volvulus is particularly common in mares post-foaling, as well as foal trauma to the GI tract. It is not unusual for a dystocia for the foal to injure the GI tract or for the mare to potentially prolapse a portion of her GI tract, of her rectum during foaling if it's a dystocia. And in those situations, if they prolapse more than about 6 inches, they run the risk of tearing the blood supply to that distal rectum and distal colon and having that ultimately die and them to present with colic over the next few days. Again, in your history, diet and water access, horses do prefer clean water, and they are more likely to drink warm water during the colder weather. Remember, the horse's diet should consist of primarily roughage, so hay and straw, etc. We do often, especially here, feed concentrates, so pelleted diets or grains, but they should be a smaller portion of their diet. Horses normally eat about, in the natural environment, they will graze about 60% of their day, so they do like to eat throughout the day. And so one cause of colic can be when horses are required to have large, infrequent meals. For example, if you feed them large amounts of concentrates just twice a day, they will quickly ingest that within 30 minutes and then spend the remaining 11 and a half hours of the day with a relatively empty stomach. That increases the risk of gastric ulcers as well as increases the risk of other types of colics. In terms of concentrates, excessive concentrates, and by concentrates I mean things like oats or grains, like sweet feeds, things that are primarily grains and are high in non-fibrous carbohydrates, so non-structural carbohydrates, starches, if you will. You need to avoid feeding large volumes at a time. It has been shown that about 1 to 1.5 kilogram meal is the largest that the horse can digest before it reaches their large colon. So if you feed a horse, for example, 3 kilograms of sweet feed or oats, they probably will not completely digest those oats before they reach the large colon. And once they reach the large colon, the digestion there will cause, the fermentation will cause gas production, alteration in fluid flux, and frequently can cause colic. Recent changes in feed are important to note. Types of feed in the U.S., we see a hay called coastal Bermuda grass, which tends to cause obstructions. Feeding round bales, again, can be very effective, but if they're left out and they get moldy, they may either refuse to eat it or cause colic. And then feeding on the ground is a big one, particularly where I live currently in Michigan, because we have a lot of sand in our soil. And we know that some horses, when they eat off the ground, are fairly indiscriminate about picking up dirt or sand while they're eating. And when they do that, they can ingest significant amounts over time. And as you see in these pictures on the bottom, the picture on the right is some sand in the large colon of a horse. This is a radiograph, and you can see the sacculation here and the sand accumulation. The smaller picture on the left is obviously a postmortem picture of a horse that had a sand impaction that we could not resolve. And you can note all the gray sand in that ingesta there. Husbandry, things like medications that are used. Has a horse been on non-steroidals for any length of time? We clearly recognize an association between non-steroidals and gastric ulcers and hindgut ulcers. Antimicrobial therapy can be associated with diarrhea, so antibiotic-associated colitis in certain areas of the world, particularly in hotter seasons. We know that antibiotics can trigger actually diarrhea themselves, so they have to, we need to be careful in their use. Preventative medicine, deworming, have they been check. This is obviously a picture of a younger horse that presented for colic and had a ascarid impaction. So again, the deworming plan, and certainly in our part of the world, we see a lot of resistance to anthelmintics. So we have to determine whether or not the anthelmintics that we're using or the dewormers that we are using, are they actually effective? And then work to develop protocols that decrease resistance while effectively controlling parasites. Housing is important. It has certainly been shown that the longer a horse is in a stall, the higher the incidence of colic. And then cribbing and other repetitive behaviors have clearly been associated with colic as well. As far as the types of colic, if you see recurrent colic, so a horse may present with a history of having mild recurrent colics that occur maybe every couple of days or every week, etc., you should think about things like a partial displacement or an obstruction. So maybe they have a left dorsal displacement. Enteroliths can sometimes sit in the colon and intermittently obstruct it, causing discomfort. Sand as well can cause discomfort. Inflammatory bowel disease and ulcers and right dorsal colitis all can potentially present with recurrent colic. Excuse me for 1 second. Previous medical history, obviously a history of abdominal surgery. We worry a lot more about adhesions that can cause obstruction or kinking of the bowel. It may cause intermittent pain or may actually cause complete obstruction, again, with severe pain necessitating another surgery. And then horses that have a history of traveling for competitions or traveling a lot, this has been shown to actually be a great model for inducing gastric ulcers. And so just simply taking a horse out of its normal environment, putting it on a trailer and taking it to a show has been shown to create ulcers. And so if they're colicky, that would be another differential you might want to consider. Obviously, dentition, horses that can't grind their feed well, whether it's because they have severe dental abnormalities like this picture on the right, or again, if they're older horses. I just recently looked at a horse that was 30 years old and had very good dental care, but his teeth were fairly worn down, and he no longer had a very good grinding surface, and so he was quitting his hay or dropping hay after chewing it for a period of time. That horse is at a little bit of an increased risk for an esophageal obstruction if he tries to swallow hay that's incompletely chewed. And so recognizing this and instituting preventative measures would be important. Again, as I mentioned earlier, the onset and duration of pain can be helpful in terms of determining the types of lesions, although it doesn't 100% rule true. But pain that is uncontrollable can often be a sign, and by uncontrollable, I mean you've done appropriate medical therapy and you're not able to control the pain, may be an indication that that horse needs surgery in some situations. So severe colic, we do tend to think about ischemic bowel, so a strangulating lesion that's cutting off the blood supply, maybe a twist, maybe it's incarcerated into a rent in the mesentery, whereas the mild recurrent colics, again, the list is a little bit different. So when I perform a physical exam on a horse with colic, obviously it is important to do a thorough physical exam, and determine, first of all, whether or not there's any other organ dysfunction that may be causing the pain, like muscle injury, pleuritis, or laminitis. And so I do strongly encourage my students to do a full physical, but I will certainly say that when a horse walks in with abdominal pain, I do initially focus my physical exam on assessing the cardiovascular status and the gastrointestinal status because of the reasons I discussed earlier in terms of my goals. One, to determine the cardiovascular status so I can institute treatment quickly if needed, and two, because it also helps me determine the type of lesion. So when I think about the cardiovascular system, my major concern is this animal showing signs of hypovolemia. This may or may not be due to actual blood loss. It may be due to third spacing of blood in the GI tract or the fact that the horse has been colicking for days and not drinking. Regardless, I want to assess this so that I can institute treatment if necessary. So when we think about the cardiovascular status of the animal and a physical exam with just our hands, we want to evaluate obviously the heart rate, the membranes, pulse pressure. All of these can potentially be affected by other things besides hypovolemia. So the heart rate clearly can go up with pain or excitement, fever or systemic inflammation, but hypovolemia for sure is one of them. And what you want to do is put the information all together. So an animal who's hypovolemic, depending on the level, will have an elevated heart rate, their membranes may be dry, and their refill will be prolonged. Their pulse pressure will usually be tachycardic but poor, so the quality of the pulse will be decreased. And probably one of the most sensitive indicators is the jugular refill. So by holding off the jugular vein, it's considered the poor man's central venous pressure. So with decreased blood volume, venous return is decreased. And in an ideal world, you would drop a central venous catheter and measure central venous pressure. In reality, we don't have the time to do that. And by evaluating just how quickly the jugular refills when you hold it off is a very good indicator of venous return and can be correlated to central venous pressure. The key with something like this is to have a good idea of normal. And so every horse you do a physical exam on, you should assess their jugular refill, and you become very astute at determining if it's poor or decreased in a horse that's hypovolemic. In severe hypovolemia, you may see cool extremities. And remember, when it's severe hypovolemia, you'll also see poor mentation. So the horse's mentation will decrease with the level of hypovolemia. Packed cell volume and total solids or hematocrit and total solids or total protein can indicate it, but remember they can be affected by other things. So an animal might present with colitis and diarrhea and have a normal total solids because it's losing protein in its gut, or it may be bleeding or some other things. So as a single unit, it can be useful, but needs to be taken into account. And really a PCV and total solids is most helpful if you have a very good history, and it's most helpful in terms of serial checks of it. So listening to the GI system, obviously evaluating borborygmi or gastrointestinal sounds is important, but it often doesn't really give you a clear indication of the type of colic. It really is more about assessing whether GI sounds are present or not. Probably the abdominal contour is more important, assessing whether or not they look like they're gas distended or bloated, as well as whether or not they've been producing manure and the quantity and quality, and then of course the appetite. Most colicky horses don't eat, but occasionally you will have one that is willing to eat even while colicking. The next exam in working up a colic, we always would try to perform a rectal exam and just kind of the structure assessment of the structures that you should be able to feel in the average size horse. Be systematic. You should be able to feel the spleen on the left body wall, the left kidney, which is just to the left of the aorta. You should be able to palpate the aorta, the bladder, the cecum on the right, and actually palpate the ventral cecal band and the pelvic flexure of the large colon. And then in males, you should always palpate the inguinal rings, particularly in stallions, to make sure they don't have an incarceration. And females, obviously the uterus and the ovaries, and then the bladder. So when I do a rectal, I go, once I've emptied the rectum, I would go in, palpate the aorta, move to the left, palpate the left kidney, move further to the left, palpate the spleen, move ventrally, palpate where the pelvic flexure should be, continue to the ventral midline, palpate the bladder, the uterus, and the inguinal rings, and then swing to the right and try to grab the cecal band, the ventral cecal band, which should be easily palpable, and run that dorsal to ventral. The key with doing a rectal palpation is to be safe and to adequately prepare the animal. So ideally, a stocks is useful. If you don't have a stocks out in the field, putting the animal in a stall against a wall and using the stall door to kind of protect yourself. The other thing that's important is sedation and potentially, if possible, an antispasmodic. So with the fairly recent introduction of the drug buscopan, which is a parasympatholytic, has really aided us in doing rectal exams. So sedation of the horse to control them and make sure they don't injure you and possibly injure themselves. Frequently, we would use an alpha-2 agonist like xylazine or ditomidine. And then we would also give them buscopan, again, which is a parasympatholytic. And so it will relax the GI tract and make it a lot easier for you to do a thorough and rectal exam. Their GI tract relaxes, they're not straining, and you can typically do a thorough exam fairly easily. Because buscopan is a parasympatholytic, it does result in elevated heart rate, and so it's important to give it slowly IV, and it has an effect for about 20 minutes. Again, rectal palpation, you want to try to accurately identify normal structures, but also try to determine if they are abnormal. And of the things I would say most commonly you're going to feel, you may feel gas distension, particularly of the large colon. Maybe normally the tinea or bands that are run along the colon run cranial to caudal, so you palpate them running towards you. If you feel them running across the abdomen, that's often a sign of a displacement. You may be able to feel distended small intestine, tends to feel like balloons, or impactions in the pelvic flexure or the cecum, or sometimes in the small colon. Again, this is a hind view so this is a cross-section looking into the GI tract, into the abdomen, is for what you can palpate. So again, I would go in, I would palpate the aorta dorsally, I would swing over and palpate the kidney, which is kind of this structure hidden here. I may palpate large bowel over here or small colon, spleen, pelvic flexure, bladder is not shown, and uterus not shown. And then the cecum is over on the right. Again, abnormalities you might feel are large colon gas distension. You may feel impactions of the large colon or cecum. They tend to feel like, if you can imagine modeling clay being packed into a bag. If it's softer, you may be able to break it up with your fingers, but if it's a very hard impaction, it really feels like clay. Small intestinal distension, again, tubular balloons, and small colon impactions, again, feel like clay, but within the small colon, which is the same size as the small intestine. This is a cross-sectional diagram, again, looking from the back of a horse of what's called a left dorsal displacement or a nephrosplenic ligament entrapment. This is a fairly common displacement that horses will get. Hopefully you can see my arrow. Normally the left colon, the dorsal and ventral colon, sit on the ventral abdomen medial to the spleen, which is this purple structure. With a left dorsal displacement, those pieces of bowel somehow migrate lateral to the spleen, so they get under the spleen, migrate up here, and get hooked over the nephrosplenic ligament, which runs between the kidney and the spleen. And it's a band of tissue, and if this large colon can get up there and flip over it, it gets hung up there. And the horses typically present with mild to moderate pain, intermittent, because as gas builds up behind this entrapment, they'll get uncomfortable. And you can palpate this. If you set up your patient well, you would go in, you would palpate the aorta, the left kidney, and you would move lateral to palpate the spleen, and you would run into the colon. And you can often feel the colon hanging off of this ligament and run up and feel that it's stuck up there. So it can be a fairly useful. The other thing, you don't have an image of this, but hopefully in the lecture on ultrasound, you'll get some images of this. You may be able to determine that this is going on by doing an ultrasound of this horse. So you would put the ultrasound probe on the left paralumbar fossa, and normally you would see the spleen and the kidney behind it. And in this case, you would see the spleen and then the gas in the colonic ingesta. So you would not be able to see the kidney. So that combination would give you a fairly good, the combination of this rectal exam as well as your ultrasound findings that you probably had a nephrosplenic ligament entrapment. So with a large colon displacement, typically, again, you have mild to severe colic. With rectal exam, you'll have gas-distended colon and potentially colonic bands that run left to right instead of craniocaudal. If you pass a stomach tube, which in my opinion you should pass on every colicky horse, you may have gastric reflux because the colon can sometimes, as it's displaced, pull on the duodenocolic ligament and obstruct the duodenum. So it acts as a gastric emptying obstruction until the horses will get fluid in their stomach. Gastric distension is incredibly painful, and so all horses should have a stomach tube passed just to determine if they have gastric distension, because decompressing their stomach can control pain fairly significantly. If you ultrasound a large colon displacement, it can often be fairly unremarkable. You may see that the colon looks tightly stretched. You may see that colonic vessels, which run along the tenial bands, are present on the lateral wall. Remember, these vessels are typically medial, and so we don't see them in a normal horse. However, if the colon's displaced and twisted a little bit, you may see the vessels running along the right ventral abdomen. Passing a stomach tube is both a diagnostic aid and a therapeutic aid. So again, because horses cannot vomit, they have gastric distension can result in significant pain. And if it's not resolved, it can even result in regurgitation and aspiration and rupture if it's not relieved. When passing a nasogastric tube, we always try to pass the largest diameter tube possible because it is easier to get reflux started if the tube is bigger. So I always pass as wide a tube as I can, even though the horses don't particularly care for it. Again, it's a useful diagnostic because you're going to assess whether or not the animal has gastric reflux, which will ultimately help you come up with a diagnosis as to the cause. In addition, it's a very effective therapy. So if the horse isn't refluxing and you can use the intestinal tract for hydration, it's a very effective way to resolve both impactions and even displacements. So it's my favorite if I can use it. Oral fluid therapy, if you are going to try to rehydrate, let's say you've palpated an impaction or you think the horse has a displacement and you're hoping that if you soften up the ingesta enough, the displacement will correct. Your best bet is to use water and electrolytes. Many people like to use mineral oil, but mineral oil is not a very effective at softening impactions and really is just a lubricant. So using an oil we don't typically use oil in our horses. We use much more water and electrolytes. If I do use oil, I use it because I suspect I have some sort of obstruction that will not soften with water. So for example, a miniature horse with a fecal lift, and I'm trying to lubricate it so maybe it'll pass. The other reason I will use mineral oil is as a marker of transit. So it's a way for me to assess whether or not the animal, when I give it, if it comes out the other end, I know at least that there is not a complete obstruction. As far as, sorry, I thought I wrote this down, maybe I did someplace else, but if you're giving oral fluid therapy with water, actually I did write it down further down. It's important to add electrolytes because this will help the water absorption. It'll be absorbed more effectively if there's electrolytes in the fluids. Abdominal ultrasound, when you approach abdominal ultrasound, it is important to scan the whole abdomen. As you get better at it, you can easily scan the abdomen of a horse, a colicking horse, in less than 5 minutes and get a fairly thorough. The goal when you're doing ultrasound is to assess motility of the bowel, wall thickness of the bowel, bowel location. And again, this is subjective. You cannot really find all the bowel and you cannot tell definitively what you're looking at. But if you know your anatomy, you can have a pretty good idea of what structures you're looking at. You also want to look for excess peritoneal fluid, determine whether or not there's potentially hemorrhage in the abdomen, etc. And then you can assess other organs such as the spleen, the kidneys, the liver, the bladder, and the uterus as well. We tend to use probes with a megahertz of 3 to 5. They have fairly good penetration, a little bit less detail, but it's important to get penetration when you're talking about a 500 kilogram horse. Remember to always try to take a little bit of time to prepare the patient. If there's a lot of dirt or water on the patient, your image is going to be poor and you're not going to get as much out of it. So cleaning them, potentially clipping and using lubricants if you have to, but for sure trying to clean them and brush off any dirt or mud. As far as to help your ultrasound image, we tend to use alcohol in the hospital. Lubricants like ultrasound gel is better, but you do have to clip the patient to do that. You can also use oil, and when in teaching labs, we will use vegetable oil without clipping the animal. The beauty of vegetable oil or mineral oil is that it allows you to apply it and it has a longer action. So when teaching, several students can image without the quality disappearing. Alcohol, because it evaporates, the image quality deteriorates over time. So this is a picture of the structures you can see on the left side when imaging. So you can see the liver. Sometimes in a horse that's very big barreled horse or is older, if the liver is shrunken, it can be difficult to see the liver because it's covered by the lung. The colon, both the right dorsal and right ventral. The duodenum can be seen in two locations, and behind the colon, but also at the cranial pole of the right kidney. The cecum, and then small intestine, typically we see down ventral in the inguinal area. On the left side, it's actually easier to see the liver, but you can usually only see a small amount of it. And the spleen, you can often see the two of them together. The stomach runs about the 10th to 12th intercostal space, right behind the spleen. And then the colon behind that, the small intestine, and then the right kidney is usually right up here under the last rib, or sorry, the left kidney. So when I am imaging a horse with GI disease, these images are taken in the inguinal area. I'm looking for evidence of small intestinal motility. In these cases, would be a very disconcerting ultrasound. The small intestine is quite dilated. It's fairly amodal, which is evident by the fact that in this picture on the left, you can see that the ingesta has actually settled out and stratified. So remember, the top of this image is actually the ventral part of the horse, and you can see in this loop, the sediment is actually stratified down and settled on the bottom of the loop with more liquid on the top. In this situation, to see that, you know there's profound ileus, because that for the intestinal content to settle out, there is no motility. The other thing that's disconcerting about this image, as well as some of the ultrasound pictures of the small intestine on the right image, is that they're quite round, which suggests that they're very distended. When you see them and they're more hexagonal or square, this suggests that even though they're distended, they're not tightly distended. Bowel thickness, these are a couple of images. The image on the left here is of the colon, so this is the right dorsal colon. To orient you, the bright white echo on the inside is the mucosa and the ingesta inside the colon, and then the wall is where the two calipers, the two X's are. This is an incredibly thick colon wall. It's 4.2 centimeters. Normal colon wall should be 3 to 4 millimeters. So seeing this thickened wall would be strongly indicative of either edema or congestion in the colon wall, so possibly a colon torsion or volvulus, or depending on the history, possibly a non-steroidal use and right dorsal colon ulcers. The image on the upper right is an image of a relatively normal colonic wall. So again, this very bright white echo here is ingesta in the wall. There's one small area where you can see a bright white line, which is the serosa. And if you were to measure the distance between these two, that would be a normal colonic wall. The image on the bottom right is of a small intestine. And again, you can see it's quite thickened, the wall, compared to normal in the pictures I showed you earlier. Seeing these types of images, again, putting it together with the other history of the case may indicate either a strangulated edematous or congested wall, or may indicate an ulcerated type of disease, or with respect to the small intestine, maybe an inflammatory bowel disorder or an infiltrative bowel disorder. Excess abdominal fluid. So here's a picture again of the colon wall. couple of loops of small intestine, and between them is a fair amount of fluid that's hyperechoic, suggesting it's cellular, would be concerning and certainly warrant tapping that fluid to try to assess what exactly it is. Which brings me to the next part of the diagnostics is a peritoneal tap or a paracentesis. So this is typically performed in our hospital using a cannula. However, you can certainly do this with a needle. So ideally, to do a peritoneal tap, you want to, if you can ultrasound the ventral abdomen to make sure that you are not at risk of hitting structures like the spleen. So you find an area where you can see either fluid or bowel. You would clip and prep. If you're using a needle, doing a lidocaine block is not indicated. If you're using a cannula, you would have to block it, make a stab incision, and then slowly advance it through the layers. Normal peritoneal fluid should look like the picture on the upper right. The very first file is very clear, slightly yellow, straw colored, the first two. And you can see the progression as it's getting more yellow and ultimately serosanguinous. Normal, it should be a transudate of blood, which means it should have very low cell count, very low protein, but essentially should have the same electrolytes, lactate, glucose of blood. Should be clear to straw to yellow in color. Protein should be well less than 2. Cell count should be in the couple thousand, so less than 7,500. And it should be mostly neutrophils with a few mononuclear cells. Belly fluid can be very helpful in determining whether or not you have a strangulating lesion, and we'll talk about that a little bit more when we talk about specific disorders. When you have a non-strangulating lesion, typically you're going to have normal color, maybe a slightly increased protein due to weeping of protein from the compromised bowel. But because it's not an ischemic event, it's a non-strangulating obstruction, such as you might see with an impaction or a displacement. There's usually not an increased cell count, and the protein may be elevated, but it's usually mildly so. So the nucleated cell count is usually low. It's yellow at most. It's not cloudy or serosanguinous. And the electrolytes and lactate would be normal compared to blood, or identical to blood. In a strangulating obstruction, the fluid often begins to get serosanguinous as protein and then red blood cells weep from the devitalized bowel. Because there's ischemic GI intestines in the abdomen, you start to get alterations in your glucose and lactate. So normal peritoneal fluid should, as I've said, should be a modified transudate. So the glucose in peritoneal fluid, the lactate, the sodium and chloride and potassium, etc., should all be the same as blood. The differences should be in the cell number and the protein. If you have devitalized bowel in the abdomen, as that bowel becomes devitalized, the tissue begins to use, because it has no oxygen supply, before it starts to die, it has to switch to anaerobic metabolism. Anaerobic metabolism requires that ATP is made anaerobically, producing lactate in the process. So glucose is eaten up because there's no oxygen, and lactate is produced. And so the fluid within ischemic bowel, as it progresses, starts to become low in glucose and high in lactate. In addition, because the strangulated bowel is devitalized and starting to leak protein and red blood cells, it will be elevated protein and potentially serosanguinous as it progresses. So these factors can be very critical in helping you determine if the animal has ischemic bowel and would require surgery to fix it. If you see a serosanguinous color, a very high protein, and a lactate that is 2 or more times higher than blood, these all are indicators that you may have ischemic bowel. Unfortunately, nothing in medicine is 100%, so finding these doesn't 100% determine that, but if you put it together with the rest of your diagnostics, it will help you in determining whether or not you think you have a surgical lesion. Sometimes, I had a horse present yesterday or 2 days ago for colic. that the belly fluid, actually this is belly fluid from that horse, and this cell count was over 100,000. So this horse had septic peritonitis. The difference with septic peritonitis, and I don't know the exact reason, he was colicky several days before and got cast in his stall, so he rolled and got stuck. And I don't know if he had a piece of bowel that was ischemic or what, but he presented a couple days later and has this belly fluid. So with a septic peritonitis, usually there's a high cell count. In this case, it was over 100,000, but usually over 20,000. Usually they're degenerative neutrophils. The key to diagnosing a septic peritonitis is seeing a glucose that is 50 milligrams per deciliter or more decrease compared to peripheral. So in this horse's situation, he was a little bit hyperglycemic in that his blood glucose was 135 milligrams per deciliter. To give you normals for a horse with that in our lab, it should be about 80 to maybe 120. So his blood glucose was 135 and his peritoneal fluid glucose was 75. So if you subtract 75 from 135, you get 55 difference. And so that is consistent with a septic process. Briefly, blood work, not always 100% helpful in working up a colic, but certainly indicated because there are times when horses will present for colic and have actually either infectious diseases or other causes. Probably the most important things we run are a blood gas, a venous blood gas, and a PCV and total protein. In a venous blood gas, the major points you want to examine is your peripheral lactate. Again, this is an indicator of oxygen delivery and can indicate perfusion deficits such as hypovolemia. Electrolytes are also critical because they're important for your treatment protocol, and they may indicate other causes. So, for example, decrease in sodium, chloride, potassium, calcium, and protein often is seen with diseases that cause loss in the GI tract, so an enterocolitis, which can certainly cause GI pain. You want to evaluate your renal enzymes, so your creatinine and your BUN to assess dehydration, and then your acid base. The vast number of adult horses that have colic that present with an acid-base derangement, so they're acidotic on presentation, will often correct that with just simple fluid therapy and do not require supplemental bicarb. However, in neonates, it's a little bit different, and they typically do require treatment for the acid-base derangement. So usually in an adult horse, if you give them crystalloids or even oral fluids with sodium and chloride and potassium and chloride, they will correct the acid base themselves once you restore their normal volume and their normal electrolyte balance. A CBC and a chemistry, again, they can be useful because occasionally we'll have horses present with colic that have other problems, so maybe an infectious disease such as an internal abscess or liver dysfunction due to colitis that obstruct the liver and cause pain. So it is valuable to do them, but they are not my first choice. And if I'm working on a case where I don't have a lot of finances, I will not necessarily do these unless I have strong indication that they will help me in my diagnosis. So now I'd like to talk about medical therapy. So how do we treat these horses? And many times we are treating them without a diagnosis. So I often see horses that present that I don't know the underlying cause, but there's several tenets that you can do to try to manage them and see if you can resolve what the problem is, even if you're not sure. So your goals are to rehydrate them and try to use both rehydration and pain management to resolve underlying abnormalities, so as well as to correct any metabolic derangements that they have. So rehydration, obviously, if you can rehydrate them using the GI tract, that's going to be your best method because you can not only rehydrate them, but you can potentially resolve any problems in the GI tract, such as an impaction or a displacement. With a displacement, we're talking about the large colon has twisted itself into some position, let's say a right dorsal displacement or a left dorsal like a nephrosplenic, which is what I just talked about earlier. In those situations, if you can empty that piece of GI tract, so if you can decrease the amount of ingesta in the colon and kind of make it smaller, it can sometimes, with motility, correct its position. And so even though it isn't logical that oral fluids will correct a displacement, many times it does, because you're able to empty out the GI tract by softening the ingesta, getting it to pass, improving the motility by correcting electrolyte imbalances, correcting hydration, and managing the pain, all of which will ultimately improve the horse's motility, GI motility, and allow them time to potentially correct that displacement. So oral fluids are a big mainstay, and I can tell you in the last week I've had 3 horses in the hospital with non-specific or non-diagnosable colic that we suspected a large colon displacement or impaction, all of which resolved with oral fluid therapy, pain management, and time. So oral fluid therapy, how do you do it? So we know that the average adult horse's stomach is about 9 to 11 liters in volume. To be safe, because it's probably never empty, you should probably never give a horse more than, in our hospital, we'll do 4 to 6 liters. I have done 8. We always do it by gravity fill, so we do not pump it in, which allows us to be sure that we're not over-distending the horse's stomach and rupturing it. So as in the picture in the top, we have a stomach tube with a funnel attached to it, and we're putting fluids in and then just holding that up and allowing it to flow by gravity. Most of the time, I would give 4 to 6 liters, and I will give that as frequently as every 2 to 4 hours. We add 30 to 60 mLs of potassium chloride or sodium chloride every other treatment. So one treatment, the horse will get 4 liters of water. The next, it'll get 4 liters of water with KCl. The next, it will get just water. And the next, it will get sodium chloride. Because we know that those electrolytes will help correct abnormalities and certainly are important in terms of motility. We always first check to see if they've got a lot of fluid on their stomach, so we will try to reflux them. And then, depending on what we find, we'll give them oral fluids. Because gastric distension does stimulate the gastrocolic reflex, many horses will get a little bit crampy after they get oral fluids, particularly if they have an impaction that they're trying to break up. And so you may have to give them sedation or walk them just to try to get their mind off it as it works through. Again, you can't use oral fluids if the horse has got gastric distension or gastric outflow dysfunction, so you do have to check them for reflux to make sure that they can actually tolerate the oral fluids. In our hospital, we routinely do it by this method up in the top here. However, you can also put a stomach tube in, fill empty fluid bags with, again, water and electrolytes, and do a CRI. So in this picture on the bottom right, the horse has a stomach tube attached to an IV line, which is attached to a couple bags that we've opened up and poured water and electrolytes in. So this fluid is going into an IV line into the horse's tube. The big concern about this is that it's important to make sure that people don't think this is sterile water and suddenly hook it up to an IV catheter. But this can be a more tolerable way for a horse to get IV fluids, enteral fluids, because it can run as a CRI and you won't get that gastric distension. However, I will say that the gastric distension and the gastrocolic reflex can be helpful when you're trying to break up an impaction. But if you have a painful horse, running a CRI like this can help decrease discomfort while you're trying to resolve this. So as I've already said, water and electrolytes have been shown to be the most effective way to break up an impaction and also to rehydrate and potentially get a displacement to correct. The use of mineral oil we use it much less commonly. However, there are situations where it will be beneficial. This is a picture, obviously, of a couple of miniature horses. the baby was was in the hospital for colic and had what we call a fecalith. I believe it was a combination of his mother's tail and some shavings, etc. In those types of situations, using mineral oil can be helpful to try to get that to pass, although in my experience, these fecaliths in miniature horses often require surgery to resolve. And again, mineral oil can be used as a marker of transit to make sure that the GI tract is patent from stem to stern. IV fluid indications. So IV fluid therapy to try to rehydrate an animal is indicated if a horse cannot tolerate oral fluid therapy. So, and this does happen, horses that have enterocolitis where they have profound ileus and they have a physiologic gastric outflow obstruction cannot handle oral fluids because they don't pass through to the small intestine and are not absorbed. So if you put oral fluids in, you just distend the stomach and cause pain. And then post-operatively, many horses will go through a period of ileus where they don't have the ability to tolerate oral fluids. In that case, IV fluids are indicated, particularly if the horse is refluxing, because this is considered an increased loss, and so you must give them some fluids to try to maintain their hydration. Otherwise, as they get dehydrated and electrolyte derangements, the ileus is just going to worsen, and you're going to end up having the whole problem get worse. When you're determining an IV fluid therapy, it's important to remember that you need to calculate for their fluid deficits that they present with, as well as their maintenance needs, and then any ongoing losses. So for example, if I'm calculating on this horse here, so it's a 500 kilogram horse, and I estimate it to be about 5 to 7% dehydrated. In addition, it has, going forward, it's been refluxing out of its stomach tube anywhere from 2 to 4 liters every 2 hours. So my deficit is 5 to 7% times a 500 kilogram horse is already 25 to 35 liters just to correct his deficit. I know his maintenance, if he's not eating, is roughly half to 1 liter an hour, so 12 to 24 liters. Again, this is much higher if they're eating, but this horse has got a stomach tube in, so he's not eating. So that's 12 to 24 liters. And then if he's continuing to lose 2 to 4 liters every 2 hours, that's another 24 to 48 liters of reflux that I have to correct. If you add these all up, sorry, I didn't do a very good job of writing this. It's 61 to, I think it was, 35, 59, 60, 79, 83 liters of, no wait, 83 plus another 24. Yeah, like 107, sorry. That should be 107 liters a day. Just to correct this horse's fluid balance. So this horse would probably need to go at a rate minimum 2 to 3 liters an hour, although I will say that it is really important to determine when you're running fluid therapy to reevaluate the patient frequently, because we often overestimate dehydration, we often overestimate maintenance needs, and so you would start with this plan, but then reassess them maybe every 2 hours. If the animal is showing signs of improved perfusion, the animal's urinating well, the animal's heart rate is declined, you may not need to go with this kind of high fluid rate. But this is the math that you should be doing if you're going to put a horse on IV fluids. Typically, we would use isotonic crystalloids, which are balanced electrolyte solutions that mimic the electrolyte composition of blood. So how do I assess whether or not I'm adequately rehydrating an animal? So urination is probably the number one thing that I like to see before I back off, because many times I'm also treating these animals with drugs that have potential of nephrotoxicity. And so I want to know that the horse is urinating. And so the frequency and the volume of urination. If we rehydrate him, we should see a decrease in his heart rate, an improved capillary refill and moisture to his gums, improved mentation, improved jugular refill, and improved pulse pressure, as well as signs that his PCV and total solids are responding. So it's fairly easy to correct fluid derangements and make sure the animal's rehydrated. But let's say you have a displacement and it's causing gas and ingested it back up, causing distension, which is incredibly painful. So you have a horse, you suspect it has a large colon displacement or a large colon impaction. You're trying to treat it medically with fluid therapy, but it has a lot of gas distension and it's very painful. What do you do there? So one of the problems is the distension results in more ileus. One of the causes of ileus is distension of the GI tract. So now you have not only distended, painful intestine causing the horse to colic, but it's not moving. So you're decreasing your ability to actually get things to resolve. So at this point, we want to try to decompress that gas or remove it safely, as this may allow the animal to, well, one, decreases pain and allow you to have more time to rehydrate and see if you can break up this impaction and displacement. And two, by decompressing it, you'll allow the motility to improve, which will ultimately help you. So large bowel trocherization is done. This is not without potential risk, but we certainly will do it in cases that are not responding initially or trying to buy time and control pain, particularly animals without a surgical option, because if you don't control this, you may have to euthanize the animal, and you have to at least try something. So to do large bowel gas trocherization, the goal, let me go back a page. So here's a picture of the colon up against the body wall. So I'm going to make you guys all dizzy. I want to go back all the way, this picture right here. So this is a picture of the right side of the horse. When we have gas distension of the colon or the cecum, we often have gas up here in the paralumbar fossa. And so when we ultrasound this animal or we rectal this animal, we put our hand over here, we feel large viscous of gas. And you may even hear a ping if you tap on this side when you have your stethoscope. So the gas distension is all up in this region. I'm going to go back. Sorry to make you sick. So the goal is to, here in the picture on the upper right here, this would be let's say the right paralumbar fossa. So we have this gas distended cecum that's right up against the body wall. And I would palpate and feel it, but then I would also ultrasound through the body wall here and see body wall and gas. So I know that if I stick a needle in, I'm going to enter this gas distended viscous. So once I've confirmed that I feel comfortable that this is a safe place, and let's say in this situation, I'm in the right paralumbar fossa, just like this picture here, I'm going to do a sterile prep, little local block, and I'm going to take a catheter, so an IV catheter, and I'm going to advance it in. I'm going to attach a little tube to it and have that tube, the end of it sticking under in a cup of water. And as I pop into this gas, it's going to be released and bubble, and I'll be able to tell that I'm being successful because I'll see the bubbles in the water. So you advance until you be successful, and because these are nested trocar catheters, you can slide the trocar back and just leave the catheter in while you're doing this. I wouldn't remove the trocar because there are times where I need to advance it again. In some situations, if you're just letting it bubble off, you may have gas. If you're lucky, you may have gas release for an hour or two, which would be ideal. Sometimes we actually attach a suction pump to get this to progress, or I might put my hand in rectally and try to help push on it, bearing in mind that you don't want to push so hard that you poke the catheter through the other side of the bowel. In some situations, people will actually do trocherization of the large bowel or cecum through the rectum. If you think about it, both through the body wall and through the rectum do result in some sort of contamination, but the reality is if it's a small hole, it should seal up quickly. And both methods do allow you the ability to hopefully effectively decompress the bowel and give the animal some time to have, hopefully with motility and fluid therapy, to resolve the underlying problem. If you are going to do it through the rectum, you want to empty the rectum out, and you want to go into the rectum with a needle in the palm of your hand, so protected until you get to that bowel viscus, and then you're going to advance that needle. The needle is attached again to an extension set, which would be outside of the horse's rectum, and you would have another individual holding that extension set with a little container of water. For me, I prefer to do it through the paralumbar fossa, as demonstrated here. But again, if the situation is dire and I don't have any other options and I'm trying to help this horse, trying to control his pain and also decompress his bowel, so hopefully things can correct, going through the rectum is another way. Typically, when we do it through the body wall like this, as we remove the catheter, we will inject some antimicrobial through the catheter to hopefully coat that area of bowel. I think that's a bit of a, I don't really know that there's a medical argument for doing that. I think it just makes people feel better. Usually this site, because it's a very small hole, if the animal has a normal clotting cascade and inflammatory cascade, just seal up fairly quickly. Occasionally, if the bowel is moving and you're not careful with your catheter, you can actually lacerate the bowel. So it isn't to be done lightly, it's to be very carefully controlled. Try not to move the catheter once you get gas. And if anything happens, if the animal starts reacting, etc., immediately pull it out. You can always re-tap it. But the last thing you want to do is have that catheter in there and the animal jumping around and potentially putting a laceration in the bowel, which is going to be a lot more difficult to heal. So sand impaction, which again, as I've said to you, is something we see commonly here. First of all, prevention is the key to sand impactions. If you live in an area where there is sand and you know your horses, and you know the horses eat off the ground, really it's about working with people to try to limit that. If they can't feed them in a feeder off the ground, putting down mats or pouring a concrete slab and sweeping that slab clean so that if the horse eats off the ground, it's less likely to ingest sand. A really nice, simple way to do this is to, if possible, create a feeder. You can get old tires that you connect together. So you put 2 tires, let's say 2 or 3 tires, old tractor tires. So you have, let's say, a 3-foot feeder, put a rubber mat under it and put the horse's hay in the feeder. This way the horse gets to eat off the ground, which many horses prefer, but isn't ingesting sand because you have a rubber mat under the hay. So really the goal with sand is to prevent ingestion. Once you have ingestion, getting rid of it takes time and effort. So if you know you have a horse with sand ingestion, psyllium, which is in our country called Metamucil, is a laxative, has been used to try to help clear sand more quickly. You can mix it with mineral oil. It'll prevent it from setting up, so you can pass it with a stomach tube. You do have to pump it in. It will not flow by gravity. Sand, really, it's about if a horse is passing manure and has sand, if you can prevent further ingestion, they will eventually empty it out themselves, but it can take several months. And so they may have intermittent colic. The classic signs for a horse with sand colic is intermittent colic, intermittent diarrhea, and then obviously finding sand when you check their feces. Because the sand can be intermittently passed, it is important when looking for sand in the feces that you check it multiple times, because I have had horses that I have checked feces for sand. It's been completely clear, and then I've checked them at another time and it's been full of sand. So it is important not to just do it once and make an assumption. Ideally, radiographs will help you, but not everybody has a radiograph machine that's capable of penetrating the abdomen of a horse. That requires a standing machine, which really are only available in hospitals. So magnesium chloride is another electrolyte solution that people will give horses. It is a cathartic. In other words, it causes both an osmotic and it is an osmotic agent, but it also causes motility, and so it can help potentially resolve sand impactions or other types of impactions. However, be aware that sometimes giving magnesium chloride could cause a horse to get fairly uncomfortable. Also, be very careful about giving magnesium with other solutions. If they absorb the magnesium, which can happen if it's given with something like DMSO, which some people will use, if they absorb too much of magnesium, it's actually an anesthetic and can put the horse to sleep. It is important to avoid repeated dosage of magnesium chloride because of this risk of hypermagnesemia and heavy sedation, or quite honestly, can anesthetize them. Pain management is key. In our hospital, probably the first drug we reach for is the alpha-2s, such as xylazine or detomidine. Xylazine is a very short-acting, fairly safe, other than it is a drug that's very dangerous to people. Detomidine is the other drug we use. It's much more long-acting. In combination with butorphanol, you may get a little bit more benefit. We do use buscopan, again, the parasympatholytic, as a pain management. It's not a true analgesic. It works by stopping GI motility, which improves discomfort. So it relaxes the GI tract. So if you've got distension or a tight twist, it will relax it and temporarily resolve some of the pain associated with it. Because it's a parasympatholytic, you'll get an increased heart rate, so you do need to monitor that. And it is relatively short-acting, but it can be useful when you're trying to avoid repetitive doses of potentially more toxic drugs. Obviously, non-steroidals, Flonix and meglumine is probably the best drug for GI pain. The problem with that drug is you do have to be concerned about using it in an animal that's dehydrated or hypovolemic, because it is toxic to the kidneys. And so you need to be careful in the frequency. It should be a maximum twice a day and should only be ideally used in a hydrated animal. So a couple of specific diseases and how do you treat them? So I have mentioned a left dorsal displacement. Again, this is when the colon, which is identified by D and E. So this is the left colon, D and E, D being the dorsal colon, E being the ventral, the sacculated colon, gets behind the spleen and hooks up over the nephrosplenic ligament. So you can see this is hanging down off of the nephrosplenic ligament. The goal here is obviously to try to get this off and slide down behind the spleen and get back to its normal position. And that can be very difficult when you've got this big, heavy colon and a large spleen. So one method that's done is to shrink the spleen using a drug that works as a sympathomimetic. So phenylephrine is a great drug. It causes the spleen to shrink due to vasoconstriction and allows the possibility of now the spleen is much smaller. Sometimes this bowel, if you jog the horse, will start to come off of that ligament. The treatment is about, if you do the math, is about 2 to 5 milligrams of phenylephrine. We usually dilute it in about 100 mils and give it slow IV over 5 to 10 minutes. Again, it does cause a transient decrease in heart rate, and so it should be monitored closely because of the big vasoconstriction and increased blood volume. The idea is to jog the horse after treatment, and hopefully this bowel will start to slide off of the ligament and fall back to the normal position. Sometimes this will happen. It may not completely happen. It may require multiple doses and multiple jogging over a day or two to get it to resolve. So we would use this in conjunction with oral enteral fluid therapy, again, to try to remove the ingesta that's in the large bowel, so it's a little bit lighter and a little bit smaller and more likely to slide off of that ligament. So fluid therapy, pain management, and phenylephrine and jogging are useful to try to correct a left dorsal displacement, or what is also called a nephrosplenic ligament entrapment. Hindgut ulcers, again, we briefly talked about this, so associated with the use of nonsteroidals. This is an idiosyncratic reaction, meaning that some horses will be on nonsteroidals such as phenylbutazone for months to years and never have ulcers. Others will be on them for a couple of days and develop them. So it is difficult to determine who is safe to use them or not. The clinical signs of colon ulcers or right dorsal colitis are usually intermittent colic associated with the use of nonsteroidals. an ultrasound finding of a thickened abnormal colon. Treatment for right dorsal colon ulcers or colitis can be difficult because it can take a long time, and in some cases they never heal. In some cases they never heal. The treatment parameters are to, first of all, stop your nonsteroidals, judicious use of analgesics, which can be difficult because you can no longer use one of our more potent analgesics, which is the nonsteroidals. So you are stuck with alpha-2s, morphine, that type of stuff. A low bulk diet can help in some situations because it decreases maybe the stretch of the colon and some of the discomfort associated. So recommendations in our hospital, if possible, is grass, because that's a high water content, low bulk food. If not, then a complete pelleted feed, such as an equine senior feed or something that is designed to provide all the necessary nutrients, but in a very low bulk. Misoprostol, which is a prostaglandin analog, has been recommended for treatment of right dorsal colitis because the underlying problem is associated with the lack of prostaglandin E2. And so doses of 2 to 5 micrograms, 2 to 4 times a day have been recommended, recognizing that at the higher doses you may see diarrhea. This is a disease that if you diagnose it, you have to prepare your clients that it may take a long time to resolve the signs. In some cases with chronic right dorsal colitis, the colon will stricture down over time, and the horses may have continued colic even once the ulcers have resolved due to the fact that they now have a strictured or very narrowed colon. These horses often require surgery and resection of that strictured portion of the colon. Proximal duodenitis, jejunitis, or DPG as we call it, or DPJ, sorry, I misspelled that. This is a enteritis that we see of an unknown etiology. It is suspected that there is a pathogen, a bacterial or viral. Salmonella has been at times suspected. Horses typically present with severe colic because they have profound ileus, profound small intestinal, and gastric distension. And remember, gastric distension is incredibly painful. When you pass a stomach tube, you typically get large volume refluxes, so anywhere from 4 to 16 liters, which is pretty impressive. The problem with DPJ is it's difficult to differentiate from a small intestinal strangulation, such as, let's say, a strangulating lipoma. Many of the findings on physical exam are similar. Horses are very painful, they have reflux, they have bowel distension, and they may have an abnormal peritoneal fluid. The keys to help you differentiate this from a strangulating lesion is that it is typical, not always, but the peritoneal fluid in DPJ is usually not serosanguinous, and the lactate is not, the ratio of peripheral blood to peritoneal fluid lactate is usually less than 2. The other thing about DPJ is if you decompress their stomach, so take the fluid off of it and rehydrate them, their pain often will lessen significantly. Whereas with a strangulating lesion, even with fluid resuscitation and decompression, they are often still painful. These horses can be expensive to treat because they can reflux, like I said, 4 to 16 liters at a time, and can sometimes reflux over 100 liters a day. And you have to replace that volume on top of their maintenance. And intravenous fluids are one of the more expensive components to treatment. And so these can be very expensive to treat. But if a client is willing, they just need time and money, because if you can keep them hydrated and keep them and provide, improve their motility by decompressing their stomach, again, maintaining electrolytes, using analgesics and time, they usually will get better. Gastric ulcers, typical history with gastric ulcers are, potentially horses that travel a lot, horses that don't have, that get fed infrequently, high concentrate diets, horses that are sick or stressed. Treatment tenets, obviously the best thing is the proton pump inhibitors such as omeprazole or aprazole. Those are all great for treating gastric ulcers. In addition, these horses should have frequent meals so that they always have food in their stomach. Because they are constant acid secretors, the empty stomach is more prone to gastric ulcers. Avoid concentrates because they tend to drop the pH more severely than hay. Hay is a very effective buffer, so it maintains that the pH doesn't drop as low. And the other recommendation is to feed hay before they exercise so that they don't have an empty stomach with acid splashing up on the squamous portion during exercise. Just to mention, because this is another fairly common problem if you do neonatal medicine, is meconium impactions in foals. As you know, meconium is the first manure passed on a baby, and it can be quite firm, and foals can sometimes get obstructed and present for fairly severe colic. An enema can be tried. A simple warm water or warm soapy water enema can sometimes resolve it, but in cases where the plain, simple, soapy water enema doesn't resolve it, acetylcysteine enemas have been shown to be extremely effective in resolving it. Acetylcysteine can be bought in bulk, and the recipe is to take about 8 grams of acetylcysteine in 200 mils of water. You should add some bicarb if you're using acetylcysteine powder. Take a 12 to 14 inch or French Foley catheter with a 30 mil balloon. You would sedate the foal so it's laying quietly, elevate its hind limbs, pass the Foley catheter into its rectum, dilate the balloon so that it obstructs the rectum, and then slowly infuse 150 to 200 mils of this solution and just let it sit. It's a retention enema, so you want it to sit as long as possible. If you can get 20 minutes or 30 minutes, then let the foal get up, and usually that will help. The acetylcysteine actually breaks down the meconium, so it actually softens it, and it's easier for the foal to pass. But it does need to be a retention enema. If you cannot buy the actual powdered form of acetylcysteine, you can actually use the liquid injectable drug Mucomist, which is a drug that's used for people with cystic fibrosis. This is much more expensive, but is easily available. It comes in a 20% solution. And if you're using Mucomist, you want to dilute it to a 4% solution and apply it similarly. You do not need to add bicarb if you're using the Mucomist. So just kind of to summarize here, I guess the last part of this talk is just to briefly discuss indications for surgery. Obviously, surgery depends on a lot of things, whether or not there's a surgical facility locally, whether or not a client is willing to either put their horse through surgery or has the financial ability, etc. Surgical success rates in facilities that do surgery regularly are fairly good, certainly much better than they were 20, 30 years ago. Our surgical success rate with large bowel surgeries is usually in the 90%. Small intestine, because of potential other complications that are more common with small intestine, tends to be lower, maybe about 80 to 85% leave the hospital, and probably a lesser long-term survival. So it's not that surgery is a bad idea. We certainly have great success with surgery, particularly with the recognition of aggressive resuscitation, etc. I think surgical success has improved dramatically over the last several decades. However, the decision to go to surgery does require several things, one of which is that the horse is a good candidate, as well as finances and is there a surgical facility local, etc. So things that would indicate to me that a horse probably should be either referred or we should consider that it has a surgical lesion. First of all, refractory pain that's unresponsive to your therapy. So if you've done your workup, let's say you have gas distension of the large bowel, you've chokerized the horse, you've used analgesics, you've tried oral therapy, and the horse continues to be painful, that would be an indication of surgery. Horses that show signs of deterioration with respect to their inflammatory markers. So we term endotoxemia. So the gums, worsening of the gum color, this is a fairly purple color, worsening of the signs of hypovolemia despite fluid therapy, weak peripheral pulses, etc., would also be strong indicators in the face of aggressive fluid therapy. Signs of small intestine, so again, these distended loops of small intestine, we decompress the stomach, yet the horse continues to be painful. These loops don't change, particularly if that's in conjunction with a peritoneal fluid that's serosanguinous and has a lactate that's more than twice peripheral lactate. Those would all be strong indicators of a strangulating small intestinal lesion, and that surgery is indicated. So again, with large bowel, refractory pain, persistent abdominal distension, as well as palpable colonic distension on rectal. And probably the last part of that I didn't include would be ultrasound findings of persistently thickened or edematous large bowel. And again, if this is coupled with a history of, let's say, a post-foaling mare, we'd put large colon volvulus fairly high on your list, and that is a surgical disease. Again, evidence of devitalized bowel, so again, persistent endotoxemia, and particularly if the peritoneal fluid looks like this, or if you do repeated taps, so if you've worked the horse up and you find belly fluid that, let's say, is clear yellow, maybe has a high protein. Several hours later, the animal's still not responding. You re-belly tap them, and now you see fluid that's serosanguinous and the protein has increased, etc. That would be an indication of devitalized bowel, which truthfully would be require surgery to resolve or resect. I think that's all I have to say for today's lecture. I'd be happy to take any questions if you have them. And I thank you for your attention.
Yeah, Dr. Carr, there are about 404 questions for you.
Okay.
So we have selected some important questions. So because for others, the answer is already available in your lecture. So the one question, if there is a gastric reflux about 15 liters per day and a colic for 5 days, what could be the probable cause?
Can you say that again? If there's gastric what? Gastric reflux?
Yeah, nasogastric reflux for about 15 liters per day.
And it's going on for 5 days, you said?
Yeah, for 5 days. A mild colic with 5 days.
Okay. So if I have gastric reflux of 15 liters and it's persistent, so it continues to reflux that amount, I would be concerned either is the horse it would depend on the level of the pain of the horse. If the horse had gastric reflux, persistent gastric reflux, but as long as I kept its stomach decompressed, it was not severely painful, I would probably think the horse has enteritis, so just ileus secondary to an inflammatory disorder. I would probably, with a horse like that, want to do a peritoneal pericentesis, because I think that would really help you determine if the horse has something that might be a surgical lesion. Truthfully, if it's been 5 days and the horse is still alive, it's unlikely that it's a strangulating lesion, but it could still have, let's say, I didn't mention this, but an intussusception or something like that is not strangulating but causing an obstruction.
Okay, thank you. Can we use warm soap water enema in case of meconial impaction?
Yes, you can. I think that's always a first line, is to try a warm soapy water enema. You don't want to do multiple warm soapy water enemas because they are irritating to the rectum, and so the animal will start to strain just because his rectum is inflamed. So I would use one or two. You can even just use warm water. You don't have to use soap. If that didn't work, I would try to, if you can have access to the acetylcysteine. The nice thing about acetylcysteine is if you buy it, it's a powder. So you can just make up small containers of it and have some bicarb, have it ready just to add to warm water and use that. So it's a very, very effective treatment for meconiums. I would always do maybe a warm water or soapy water enema first, because that's going to resolve some. But if you have one that's very difficult to resolve, acetylcysteine is going to be the best thing you can do.
Thank you. Regarding sand colic, psyllium you advised to use 2 kg with the mineral oil. Would you suggest the dosage of mineral oil?
So
How much mineral oil with psyllium?
yeah, so the key is to mix it up enough so that you can get it into the horse, because that's quite a large volume of psyllium. So I would probably use about 2 to 4 liters of oil, depending. You have to mix it and you have to pump it with a stomach tube. So maybe 1 kilogram per 2 liters, and then repeat it twice a day might be the easier way to do it.
Would you suggest what are the practical prognostic indicators for colic?
Practical prognostic indicators, if you're doing an appropriate treatment, so you're trying to rehydrate the animal, etc., decompress their bowel, like chokerize them, if they are persistently painful and persistently tachycardic, those are poor prognostic indicators. The evidence of toxic mucous membrane, so purple or and poor pulses, is also that's persistent over days or worsening over days is a poor prognostic indicator. Persistent or increased total hematocrit or lactate in the blood are poor prognostic indicators over time. So if you're treating a horse and over a couple of days those things increase, those are poor prognostic signs. They all probably indicate something that needs surgery, and so if that's not possible, they would all be indicators that probably the prognosis for medical therapy is poor.
Thank you. Ma'am, you are telling about the intravenous fluid therapy.
Mm-hmm.
Would you suggest what is the rate? How fast we can give to avoid the damage, to avoid maybe pulmonary edema like that? What is the recommended rate, speed which we can give?
So the good thing about horses is you're never going to be able to give it so fast that you can cause pulmonary edema, at least in adult horses. Normal horse, we routinely would give, if they're dehydrated, a rate of 2 to 5 liters an hour, depending on the level of dehydration. So normal maintenance is about 1 liter an hour to maintain fluid therapy, 1/2 to 1 liter an hour. If you're trying to resuscitate them or correct dehydration, on mild to moderate, 2 to 3 liters an hour. If you have an animal who's shocky and very hypovolemic, you can start out at 5 liters an hour and then slow it down accordingly.
Okay, thank you, ma'am. Peritoneal tap, you said it's an important diagnostic aid. So do we have any contraindication in a pregnant mare?
So the biggest contraindication in a pregnant mare would be trying not to tap the placenta or the uterus. So that's where ultrasound guidance is helpful. So in a late-term mare where I know the uterus is probably down on the ventral body wall, I would have to ultrasound them to try to find a place that I could tap that wasn't the uterus. Otherwise, there's not really a contraindication if you can find a site. The thing to remember is if you do a sterile prep and you tap the amnion, let's say, it shouldn't be any greater risk. You should just remove the needle and realize that you weren't successful. So the only time it would be a risk is if you introduced contamination into the placenta, which if you did a sterile preparation should not be a risk.
Okay. For how many days we should give psyllium with mineral oil for sand colic till it responds, or is there any number of days beyond which we are not supposed to give?
There isn't really a number of days. That volume of psyllium is quite a large volume. I tend to do that when I have a horse presents to me with severe colic and a large amount of sand in its abdomen. Then usually I will do that for a couple of days. until the horse is, so it's going to take a long time for the sand to clear completely. And so the horse is probably going to experience intermittent, milder episodes of pain. Usually when they present to me, it's because the sand has obstructed them. And so I'm trying to break down that obstruction and get things moving again. Once I've done that, I would stop doing that large volume, and I would send the horse home and have the owner give them daily doses of a smaller amount, like maybe I'm trying to calculate it into mils, maybe 250 mils every morning in their feed until they get it cleared. So they don't necessarily have to get the large volume. They could use, let's say the owner can give 250 mils every morning until you stop seeing sand coming out of the rectum and the horse stops colicking.
Thank you. Is there any guidelines for the nasogastric tube to be in place? Beyond how many days it should not be kept?
That's a really good question. There's no perfect answer. The big risk with a long-term placement of a nasogastric tube is that they can get irritated on their esophagus, and occasionally they can get ulcers in their esophagus right at the entrance to the pharynx, because that's where the tube is going to bend and rub against the esophagus. And so if they get an ulcer there, rarely, but sometimes they can actually get an abscess or perforate their esophagus. So I have left stomach tubes in horses when I've had to for a week or more, but I don't do it with any, I worry a lot about them because they do have that risk. Ideally, you don't want to leave a stomach tube in for more than a couple days, but sometimes you don't have the option if they've got ileus and they've got gastric reflux. Things that will help you, or things to look for, is you should make sure your tubes don't have any nicks or rough spots on them, because that can act like sandpaper and irritate the esophagus. So I would always take very care that my tubes are very smooth. Some horses, when you put a tube in, will constantly stretch their neck and gag and move their head and neck back and forth. And so that tube is moving back and forth across the esophagus. Those horses, I'm more worried about leaving it in long term, because I think that increases the risk of creating an ulcer. Sometimes when I have a horse that's got a tube in for several days, I will take the tube out for a period of time and try to give them a break, recognizing that I'll probably still have to put it back in. The other thing you can do, although it's harder to get reflux out, is you can put a smaller tube in, which will be less irritating to them. The hard thing about that is it's more likely to get obstructed with feed material, so it may not be as good to decompress their stomach.
Thank you. For the fluid therapy, I've been telling about isotonic fluids or crystalloids. How about usage of colloids in case of shock? If so, what colloid would you suggest?
So that's a really good question. In the human literature, in an acute shocky situation, if you have crystalloids, they're as effective, and probably they're definitely been shown to be equally effective. So colloids are not really indicated unless you have severe hypoproteinemia or blood loss where you feel like you need to increase your oncotic pressure. So if I had an animal that was severely hypovolemic to the point where I didn't think I could get, let's say, 30 liters of fluids into them quickly, rather than reach for colloids, I would reach for hypertonic saline. So hypertonic saline, it comes in different concentrations. What we use is 7.2% sodium chloride, which is 8 times more sodium and chloride than isotonic. So isotonic is 0.9%, hypertonic is 7.2%. So 2 liters of hypertonic saline can be given very quickly and be a resuscitative fluid and allow you time to get more of the isotonics in. So if I have a patient that I think is profoundly hypovolemic, and I don't think I have enough time to wait to get for that volume of fluids to get in, that 30 liters or 40 liters, I will use 2 liters of hypertonic and then follow it with isotonic crystalloids.
Thank you. Thank you so much for the patient answering for so many questions. We really enjoyed the whole class, and then the audience would have got very much benefited. Thank you, Dr. Carr. I request Dr. Aaron Prasad, Professor and the Head of Resident Veterinary Service Section, for his concluding remarks.
Hi. Hi.
Hello.
Very good morning. How are you?
Good.
Yeah. So a very good evening to the participants also who have been joined with us, and so patients to be here with us. And this topic, as a colleague, so you have given a ready reckoner like lecture. So the practitioners could have been enjoyed with that, and a lot of information has been given with a very short time. So we thank you, really thank you from our side. So really this served our purpose of getting this webinar to be spread all over the 12 countries who have been joined with us for this. We really thank you, man. Thank you for the efforts you have taken. So you have mentioned a few of the things that miniature horses that have been fecolids. So we experienced a lot of enterolids here, over here. So which is one of the case which is almost a football-like size of, over the size of football. And other case, a month back, we had a case of intestinal entrapment through the left dorsal border of the diaphragm, which gets entrapped into the thoracic cavity.
Wow.
So is that could be the sequelae of the colic, or because of the damage in the diaphragm, it would have gone in? So we had a very good pictures of that. And so what do you think of that?
Well, we do occasionally see tears in the diaphragm that result in, intestine slipping into the thorax. They're frustrating because many times you can't repair the diaphragm because of its location. We suspect, nobody knows for sure, that some of them occur due to a kick or an injury that the horse sustains and tears your diaphragm. Some of them, interestingly enough, I don't know with yours, the tear looks like it's old. It's very smooth edged and looks like maybe it happened a long time ago, and then just unlucky horse, it happened to slip through. Years ago, I had a weanling that had a huge tear in his diaphragm and had his large colon in his chest, and he wasn't colicky. He was just a failure to thrive, so he just didn't grow well. And in that case, the large tear allowed him to continue to live, but he just wasn't doing well. So they are they're rare, but you should have them on your list. You're right. It's a great one to bring up. It's a good point. Thank you.
Yeah, thank you. And few of the cases we noticed during when gelding, we encounter inguinal hernias.
Okay.
Yeah, so that's again a fantastic one. So it's a very good presentation you have given for us, and hope the practitioners would have got benefited by it. And we are so indebted to your patience for presenting for more than an hour or two. Very thank you. Very kind of you.
You're welcome. I enjoyed it. I hope that people got some useful information out of it.
Yeah, thank you. It's a ready reckoner for us, for the practitioners. Total from the gastritis, whatever the thing which needs to the colic in horses. So if they're just going to refer your recording, so they can get the point out of it. Very thank you.
I did put my email address on my first slide. So if people do have specific questions, feel free to email me. I'm happy to try to respond.
Sure. Yeah, thank you. Then I would give a conclude on Andres Contra, who had spoke about the adipose tissue manipulation in periporcine cows. So it's a very good, excellent presentation. So wherein the 3 weeks period before the delivery and 3 weeks after the parturition is a critical period. So the molecular changes would have made a change, will make a change in the economic impact in the owners, the farmers, as well as the country. So he had mentioned about how the insulin responsive during that 3 weeks of period before parturition and after parturition, making changes in the negative electrolyte balance, negative energy balance, which leads to a inflammatory response and producing oxidative stress, which releases the fatty acids and the glycerol, which leads to metabolic changes. So this gives an enlightenment for the practitioners as well as the academicians to think of the last part of that is 3 weeks of the before pasteurization and 3 weeks after pasteurization to look into the metabolic changes, so which leads to very impact on the economic downfall in the animal, milk yield or any other thing. So I would like to conclude that it is a very good presentation from the contrast, and also I thank Dr. Elizabeth Carr for her presentation on the patients. Thank you.
You're welcome.
May I request Dr. Mehdi, Assistant Professor, for proposing vote of thanks.
A very warm good evening.
Hello.
Good morning. At the outset, on behalf of organizing committee, TANUVAS Global Veterinary Large Animal Science Webinar Series 2020, Day 2, entitled on Reproductive Ultrasonography in Mares and Stallions, Medical Management of Colic in Horses, and Molecular Adipose Tissue Function in Peripartum Cows, I express my heartfelt gratitude and thanks to our beloved Honorable Vice Chancellor TANUVAS, Professor C. Balachandran sir, for giving necessary permissions to conduct the webinar successfully and his constant support. Thank you, sir. I express my deep sense of gratefulness and thanks to the Director of Clinics TANUVAS, Professor S. Balasubramanian sir, for his meticulous motivation, constant support, inspiration, and encouragement. Thank you, sir. I express my sincere thanks to Dr. G. Andres Contreras, Associate Professor, Large Animal Clinical Science, College of Veterinary Medicine, Michigan State University, USA, for his kindness in accepting the invitation and giving an elaborate, nice lecture on modulating adipose tissue function in Peripartum cows. Thank you, sir. I express my heartfelt, sincere thanks to Dr. Elizabeth Carr, Associate Professor, Associate Chair, Large Animal Clinical Sciences, College of Veterinary Medicine, Michigan State University, USA, for kindly accepting the invitation and delivering an excellent and awesome lecture on medical management of colic in horses. Thank you, ma'am.
You're welcome.
I thank Mr. Karunanidhi, Vice President, Alembic, and Dr. Santosh Shinde, Alembic, for their constant technical support. On behalf of organizing committee, I sincerely thank the Dean, Madras Veterinary College, and Dean, Basic Sciences, TANUVAS, for providing necessary facilities for conducting the webinar successfully. I sincerely thank deans, faculties, and students of all constituent colleges of TANUVAS, students and practitioners of India and abroad for their constant support and participation. I thank Dr. P. Tirunavukarasu and Dr. N. Vimal Rajkumar for their technical support and coordination. I thank all the members of organizing committee, my seniors, my colleagues and subordinate staffs for their support in conducting the webinar successfully. I would like to thank everybody who have helped for successful conduct of the webinar, as well as expressing apologies that I could not mention personally one and all. Last but not the least, I thank the Almighty who is indefinably yet directing and guiding us in a right way at every moment. Thank you all. Goodbye. Bye-bye.
Bye-bye.